after an interesting day 1 session. Today we are with the day 2 session, and today we have with us Professor Dr. Sarita Bajaj. She is Director, Professor and Head of Medicine in MLN Medical College, Prayagraj. She is the immediate past President of RSSDI. She is the President of API UP chapter and the President of Wendy and Safi's group. Then she has been the past president of Endocrine Society of India, and we know her as a lovely mentor and teacher to all of us. So I welcome Dr. Sarita Bajaj to take over the session.
Thank you, Vaishali, for the kind words, and thank you to Torrent for organizing this. And welcome to day 2 of this truly holistic webinar on wellness and women's health, with women's voices from across the globe. And we have specialists. There's a wide variety of specialists here. Congratulations to Tejal and Gagan for the resounding success of yesterday's webinar, with almost 4,000, close to 4,000 attendees. But with the topics lined up today, I think we will have another blockbuster. So it's a pleasure to introduce my co-chairs. Yeah, it's a pleasure to introduce my co-chairs, Dr. Vivian Lim from Singapore and Dr. Mimi Giri from Nepal. Vivian has also held several prestigious posts and organized endocrine conferences in Singapore. She is the chairperson of ICE and the Asian Federation of Endocrine Societies for 2022 in Singapore. Mimi has held important posts in the ADA Belgian Endocrine Society, Diabetes and Endocrine Association of Nepal. The rapporteur for the first panel on how well do women cope with chronic disease is Dr. Vaishali Deshmukh from Pune. She's a gold medalist in the DNB and one of the first women endocrinologists in Pune. She is doing a lot for women and for the girl child with special interest in mental health. We have two brilliant panelists with us, Dr. Komal Verma from Gurugram and Dr. Aarti Behel from Mysore. Dr. Komal Verma has varied experience and research in training, teaching, mentoring as a psychologist and well-being expert. Aarti has special interest in mental health in women. Over to you, Dr. Vaishali, for the first panel. You are not audible. Vaishali, you are not audible.
Okay, thank you, madam, for that kind introduction. And I will be sharing my screen to show what work we are doing in coping strategies in women. So it will be a brief slide presentation followed by panel discussion with our eminent panelists and chairpersons. So this is to begin with. Can my screen be seen, madam?
Yes, we can see, but I think PowerPoint, you need to do that.
Yeah, okay.
Yeah, full screen, that's right, perfect.
So basically coping, emotion and stress, all three are interlinked, and the common link between the three is that they predispose a person to chronic disease. So you can see the neural, hormonal, as well as the inflammatory pathway all producing a pre-ground for formation of any chronic disorder. And we all know that any stressor in the body, the person tends to either fight, flight, or face it. So this is where coping comes into play. So we know about diabetes distress also in our practice, and it's a very prevalent condition. Nearly about 50% of Indians tend to have it, with a lot of feeling of worry, stress, and frustration and burnout, which comes as a result of coping with chronic illness. Many times we see depression and reduced quality of life, and all this translates into an unhealthy behavior, a poor self-care, and a poor coping mechanism. So coping is definitely hampered by this. And you can see that the distress level is more in women. So this is a study from Chennai in India. The distress in women comes to the tune of nearly 46%, while men tend to be relatively less distressed because of various reasons. Like women tend to feel powerless, they have worries, they have frustrations related to illness, fear of loss of control, poor confidence, a negative social image. Then they are treated differently, they tend to have a low self esteem, and they feel insufficient in terms of handling the stressors. The slightest difference between the way males and females handle it is mainly in this fight flight response. You see that the major approach in males is a fight response, while in the major approach in a female is a face response. So most of the females tend to have an emotion focused approach. So you see that in handling stress, females are more stronger as sex because they have an additional hormone of oxytocin coming into the role apart from cortisol and the epinephrine and norepinephrine. So they tend to seek more support from friends and groups. They adjust better, they let out their venting of all their emotions through various activities, even crying, very simple, meditation, mindfulness. And of course, some patients go into denial and self blame also, which leads to negativity associated with coping. So there are a lot of techniques which we are working on where mind body medicine interventions work. Even there is a sexual difference between which practices are tended by which sex. So yoga, meditation, massage are preferred as techniques by women, while men tend to prefer more of progressive relaxation and guided imagery along with yogic practice as a mode of therapy for mind body health. So what do we do in our own center? So we have practical ways to implement these coping strategies for our patients. So first and foremost, we try and empower the patients through various support group activities, especially for diseases like diabetes and thyroid. And we have these annual gatherings and meets of patients coming together with talking to each other, talking to us, and getting a vent out of their concerns. Then comes this, in Marathi, we call it as diabetes gappa, means it is a chat. It's a chat between individual patient and the doctor. So it's a motivational chat, which we have it once in a year, where we gather together, we talk about our concerns with the doctor, with the counselor, with the educator. And I think this has worked very well for our patients over past few years. Then empowering through knowledge and adequate education has been our primary focus. So education programs for various disorders, not only diabetes, has been a key point in improving these coping strategies. Most of the times our diabetic patients find that they cannot exercise, they cannot move their legs, they cannot twist and turn. So we have tried to do physical activity training workshops for patients of diabetes who are relatively disabled or rather mentally disabled to accept exercise as a modality. Not only is physical health our concern, we do conduct mind body medicine workshop for these patients, and this helps in making them mentally more strong. This is an interesting thing which we have been doing for years. It is distraction and relaxation techniques. So these are school teachers, these are diabetic teachers. They actually develop some hobby or they like it, or we can be doing it in groups. So this is Ganpati making by teachers in their own schools. So it is a sort of artwork, or you can say handicraft work, which takes away from their all the, you can say, stressful situations in their mind and helps in their diabetic control. Then these are some activities done for type 1 diabetes, where beauty contests. So making them have a good power, esteem feeling for themselves. So this is one of a patient who got selected as Miss Diabetic Queen. So that was a very good thing. And like you could see that it took a lot of motivation for her to take part in this contest. And she was really thrilled to have this title achieved. And I think this is what is required for our patients. They need confidence building. Then comes national community education programs. So we do it for certain groups of patients. So these are group of hypertensive and diabetic patients from the National Insurance Academy, where teaching on prevention of complications through practical means have been done. Then we have what we call as mother-daughter talks in various schools. So you get the mother along the child to understand the normal puberty, the growth disorders, and we could identify a lot of growth problems and pubertal issues and endocrine issues coming at this. We could prevent a lot of childhood obesity, PCOS, because of these kind of activities done annually as a part of school health. Then comes the doctor's training. So training doctors on hormonal health in women is a very important aspect, because most of the doctors are not aware of hormonal issues in women. So training every general practitioner is very important. Similarly, the IMA, that is the base level general practitioner, should be able to identify growth disorders. This has been our motto since long. So it has also worked well to identify short statures and pubertal delays and lot of patients with endocrine disorders in the childhood. Then mind body medicine workshop for doctors have not only helped the doctors, but they have helped us propagate it to their respective patients, so that they could take it through forward to their respective clientele also. Then this is a clinic based approach. You can see that wellness of women clinic is what we practice or we have, which caters to women from 0 to 100 years of age. So it is like women health from birth till geriatric population, which focuses on diet, exercise, stress handling, hormonal disorders, reproductive health, and different aspects of counseling. This 2-minute mind body clinic has been a recent addition to this, and it has worked wonders to help the psychological health of all the women who come to our clinic. We have a program for cancer survivors, which is called as Winners of Life program, because my husband is an oncologist. So basically, all his cancer survivors attend this program to overcome the post-traumatic events that they have faced during their treatments as a cancer patient. So I think all these programs have helped empowerment of the patient and coping with stress. So final tips that we offer to our patient is that you need to listen to yourself. You need to open out. It is very important to open out to the doctor, to the family, to the friend. You need to be a part of the group discussion. We encourage that they form groups along with other patients and they discuss their problem. They eat right and exercise at least once a day for the mind and for the body. So this is what I wanted to share with all of you. So I will be coming now to the panel discussion on these topics, and we have eminent panelists and international experts with us today. So welcome all of you, and I begin with Dr. Aarti. So Dr. Aarti is a psychiatrist. So I would like to know, Dr. Aarti, how do you really differentiate between diabetes distress and depression? Is it the same or is it a different disorder?
They both are definitely different. Now, diabetes distress is an emotional reaction that surrounds the life related to diabetes. So the person will report of distress only in areas related to diabetes, like the lifestyle management, or it could be the daily self-maintenance regimen, or coping with the complications or role changes due to diabetes. She may enjoy other parts of her life, that may be including hobbies, or say socializing or meeting up with friends, etc. Her sleep and appetite may not be disturbed. Whereas depression is actually a syndromal diagnosis in which a person has to qualify for 2 out of 3 major criteria and 3 of the minor criteria. Now, the major criteria, the first one says that the person should have a pervasive sad mood. Pervasiveness means that the sadness pervades into all aspects of the person's life. So it will not be related only to the diabetic distress. Second is anhedonia, that is lack of pleasure in doing any activity. So she'll not enjoy doing anything at all. And the third is energy or lack of energy. And the minor criteria are helplessness, hopelessness, feeling worthless, having suicidal ideas, or having lack of concentration, sleep, and appetite disturbances. So they both are definitely different entities. And diabetes distress can be handled by the team of doctors and nurses who take care of the patient itself, by a bit of psychological counseling, also tailor making her self-management programs in such a manner that you empower the patient and you make her feel that she is in control of the illness.
Yeah. Thank you, Dr. Aarti. I think it is important to differentiate the two, because one needs specific treatment from a psychiatric perspective. So, Dr. Komal, I wanted to ask you, what is the role of mental health in managing chronic illnesses, especially in women? What do you feel?
Uh, Hello.
Yeah, we can hear you. Go ahead.
Yeah. Okay. So when you talk about the role of mental health, definitely mental health and chronic illness coexist, and there is an ample evidence also and research which proves that there is a positive correlation. But the point is, if we all know that, and if we know, are we addressing it? Because we all know that with new advancements in all spheres of medical treatment and industry, we are living longer. But are we living better? That's the question. And I suppose this is the question posed to all the health practitioners. And holistic healthcare is something which is the answer for it. Uh, and it is rather sad, to know that most of us nowadays know one or the other person who's suffering from chronic illness, like diabetes, arthritis, hypertension, cancer, and so on. And maybe they are getting medical attention. But what about the accompanied psychological issues that they are facing, such as anxiety, depression, guilt, as you said, hopelessness? Because we all understand, once the individual is diagnosed with chronic illness, the person goes through three stages. First is panic, frustration, and then traumatization. And all these are accompanied with psychological symptoms. So, hence, a person managing a chronic illness is maybe twice more prone to mental illnesses. And it is not only because of the physiological factors which we are talking about, but definitely the related potential stressors along with it. It can be unforeseen future, or maybe adhering to the treatment, new lifestyle, hospitalization, financial burden, and so on. The list goes on. So hence there is definitely a role of mental health in managing chronic illness. Yeah.
Yeah. Thank you so much. So, Dr. Vivian, what do you feel that is there a role of the treating physician in dealing with the psychology of the patient, especially as women are considered?
No, I think that's very important because a lot of us, the most greatest barrier for treating our patients, I think, is a very, very busy clinic. We are all very trained with the hard part of the science. So we only think of a fixed thing. This is a disease, this is a hard thing. I need to treat it with a drug and that's it. But what they forget about is that the entire psychology of makeup of the particular patient, females against males, are different, and this would be a very great barrier to treatment. What we want is to treat the disease, but if the patient depends on the stages of grief they are. As you know, there are 5 stages of grief: anger, denial, bargaining, acceptance, and depression. And they can move in between the stages. So if you get diagnosed with a chronic disease, you might face already these 5 stages. And then on top of that, if you have to deal with it in your daily life, with all the burdens that a woman might have, that might be a great psychological barrier with adherence to the treatment plan that we have given to them, and to the fact that they might not even come back to see us. If they are in the denial stage, if they are in the different parts other than the acceptance stage, we will have a very, very great problem getting them to focus and deal with the disease and their management. And that's why I think that psychology is just so important. We really need to sit down and get from them a risk factors of whether they actually are in any psychological distress, and that would be a barrier to our treatment for them. If not, we would not be able to treat them properly at all for any chronic disease.
Thank you, madam. I think you've given a wonderful insight that we should not be neglecting the psychology when we are thinking of bodily ailments. So, Dr. Mimi, I want to ask you that most of these patients with chronic illness, they tend to avoid, or rather go into a denial. So, is it more common with women?
Well, the simple answer is yes, because actually there is also a cultural belief that women use more emotion and passive coping methods than men. So women tend to modify their emotional response to stress, right? Whereas the men, they try to go for more for the problem-solving approach. However, studies have shown that should you correct for the socioeconomic circumstances and the social cultural circumstances, women also, there is no difference between the genders for the problem-solving approach. However, on the whole, there seems to be a structural tendency for the women to use more avoidance coping techniques, avoidance or emotional coping techniques. And whether this is because of stereotyping in gender role, or whether it is because expectations of society or structural components, we do know that women do tend to use more the avoidance techniques than the men, and this leads to greater incidences of depression in these women. So I think we as a whole, as doctors associated with people with diabetes, we should actually delve a little bit deeper into these aspects of women so that we can direct them and try to change their behavior to more maybe problem solving approaches and acceptance, rather than letting them go on, because they always relate family health and family situation, and because of stereotyping they take second place, and avoidance is very common. So I think we need to change that when we are talking with patients and when we are counseling them also. More, as you said, which was brilliantly said, more opening up, use social support, and basically make sure that their voice is heard, in my opinion. But yes, they do avoid more.
I agree with you that people need to be more vocalized in terms of expressing their concerns and feelings. So, Dr. Aarti, when and how should be looking for psychiatric disturbances in our, say, diabetic or chronic illness patients?
See, we generally see that, most physicians are very uncomfortable in asking questions related to emotional health of, a patient. They either feel like ma'am was just suggesting that, it eats up into their OPD time, or they feel awkward in asking these questions. But actually, if you see, you've established such a good rapport with these patients, they come to you with so much of trust. Then where is the awkwardness? If you ask them questions related to emotional health, for all you know, they're just dying to tell someone about their emotional health or whatever, they are suffering from. And always remember that, there's no health without mental health. So whatever you do for your patient, unless you address the psychological needs of a patient, you'll never be able to satisfy a patient. So ask them just two brief questions. Like, I know, it really takes into your OPD time. So there are two specific questions in the primary health questionnaire that have a very high sensitivity for depression. The first one goes like, in the past 1 month, have you been bothered by feeling a lack of interest or displeasure in doing things? And the second one just says that, in the past 1 month, have you been bothered by feeling down, depressed, or hopeless? These two questions are barely going to take 2 minutes of your time. Uh, by the time you get out of your awkwardness of asking these questions, I'm sure, the patients are going to feel very, very relaxed talking to you about their emotional health. Now, the ADA says that, you should be ideally be assessing the psychological health of a patient at the time of initial assessment, annually thereafter. Uh, if the patient develops any kind of complications due to diabetes, if there is a change in the treatment team, or if there is any major life event in the patient's life, like birth, death of someone, or, a change in job. But I think with these two simple questions, any of you can ask at each visit.
Yeah, I just timed it up. It takes only 20 seconds, not even 2 minutes. So I think 20 seconds of that question is just sufficient to identify the mental.
Absolutely.
Yeah. So Dr. Komal, do you feel that women behave differently when it comes to psychological challenges in coping?
Yes, definitely, because psychological makeup of males and females are quite different. And it is definitely governed by the society in which we live in. Because as you all said, because there are two techniques, emotion focused and problem focused, which males and females use. So, and the base is, because women are socialized to be other focused and men are socialized to be self focused. So, this is a major roadblock and major challenge which females have to overcome in handling their chronic illnesses. Because it is said, because a woman diagnosed with chronic illness can experience difficult thoughts and feelings. And these can be sense of failure, anger, helplessness, which is directly linked to feeling of guilt, frustration, anxiety, and depression. And these are the haunting thoughts, which are really burdensome on one person. And if I say, people actually or females actually start asking themselves a question, why me? I'm a failure. Or, now I can't be an idle bahu or daughter-in-law. So how I'll manage things? And this takes a toll on person's health and definitely creates a lot of hindrances. And in our society, especially, log kya kahenge? Because the home will not be managed, how you'll manage your office. So there is a lot of chaos in person's life. So chronic illnesses diagnosis come with definitely a lot of treatment challenges, including stigmatization, which is happening. And we have a lot of examples, we talk about Sonali Bendre or Lady Gaga. They have faced this chronic illnesses and they have fight back, and they have actually, if you just read their biographies, they say that it's all about self. So you have to understand and overcome your self-esteem and enhance it, because ultimately you need to take care of yourself. So this is the major challenge which women have to take care of.
Yeah, that's a wonderful insight. I think women need to take care of their own mental health. So, Dr. Vivian, coming back to you again, do you feel that proactive or positive coping is going to help in adherence or compliance and outcomes as far as chronic illnesses is considered?
Oh, absolutely. I think that if you're going to deal with chronic illness or actually any illnesses, if you're going to be reactive to it, if and you're going to passive about it, that comes with a lot of difficulties. But if you want to proactive, you want to take control, then you would be able to cope with it. But the problem here is that for females especially, we walk a very tight rope in society. You juggle careers, you juggle family, your mother-in-laws. There are even jokes about mother-in-laws, your own mothers, and your own
Mm.
parents, and your children. So they are all of them are priorities. And where would then women be on that scale of priorities? So before they have gone into chronic illness or being diagnosed as one, their rope is already so tight. There's nothing else that you can put on that scale. That would be a straw that breaks a camel's back. And then now you are diagnosed with that chronic disease and you have to face the same problem day in and day out, and it becomes worse. For example, obesity, diabetes, all the metabolic conditions that come with it. Now, that is what happens is that they've lost suddenly that sense of control, and that identity of themselves being this power woman that has to just keep going, going, going. That's totally gone, and it's just swept out under their feet. So I think that actually makes them go into depression, goes into denial, goes into all those stages of coping that we are talking about. And we need to really empower them, as you have pointed out in their slides. Give them empower, give them knowledge, whatever we need, identify these people that we need then to support whichever way we do it. Whether I send it to my esteemed colleagues, my psychologists, my psychiatrists, my clinician nurses to support them, my dietitians, everybody needs to come in as a holistic approach to get them up back onto that tight wire and walking it comfortably again.
I think Madam has given a very important tip to all of us that we should utilize our staff, our support team to help the mental health of each and every patient. I think that's a very important task. Even if you don't have time, your staff member can definitely afford to dedicate that. So, Madam Mimi, can you just tell me whether women tend to be more clinging towards faith, religion, and spirituality to cope up with their stresses? Do you feel so?
Well, what we do know that women are considered and are generally more religious than men. What has shown is whether you call it religion or you call it spirituality, does result for a woman in improvement of mental health. We've gone on about the mental health, importance of mental health in women. So since there is an enormous improvement in mental health with spirituality or religion, as opposed to with men, actually there is more improvement in their physical health as well as mental health. So since we are going to focus about mental health for women in coping with their chronic illnesses, spirituality does seem to have a very strong effect for that. And strong believers seem to cope better with chronic illnesses than the non-believers. So I do think that women, because of their being more religious or being more spiritual, are already helped by the fact that they could cope better mentally with their chronic illnesses. So, well, whether they really turn to spirituality or whether it was already in them, especially in our society in South Asia, is not important, I think. I think we as doctors should, if we find that they are more spiritual, we should encourage that rather than the tendency to mock, to say, religion is this, religion is that. If it is important to them, it can be a tool to help them actually progress and process their chronic illness and cope with it better ultimately. So, yes, they do tend to cling to religion, but it's a good thing because it will help them cope better.
Yeah, I think it's a valuable addition to their spiritual healing and mental healing also. So, Dr. Aarti, when do we refer such patients to a psychiatrist and when do we actually?
Vaishali, we
Yeah,
need to wind up. I don't,
okay.
we just have exactly a minute to go. I'm
Okay,
sorry.
so then I think I will directly go to our international experts.
Yes, please.
give
30
their
seconds each.
practices and views which they follow at their centers.
Yes,
Yeah, I'm
please.
sorry, Aarti, that I could not take your further questions, but definitely we will answer this in our Q&A session further. So, Dr.
So
Vivian, can you go ahead, Dr. Vivian and Dr. Mimi?
okay, I'll just say a few 30 seconds. Actually, in my opinion, women do suffer more from stress than men. That is one thing. So whenever I'm in my practice, I will make sure that I tackle that part in the consultation early on again, whether it is stereotyping, whether it is mother-in-laws or mothers, because that is a very important aspect in our society, is the relationship between mother-in-law and the daughter-in-law. So what I do tend to encourage is active coping strategies, for example, social support. If it's not the mother-in-law, then the mother or sister or friends, and also an active plan and confrontation, because I think that does result in better psychological adjustments. So I'm very focused on that. And it takes me half an hour to counsel them.
Oh, wow.
I actually agree a lot with my international panelists, Dr. Mimi here. And I feel that what we need is time in the clinic.
Yes.
If you don't have time, you can't tackle it. I need at least 30 minutes and more, and I feel that the rapport is important. And perhaps not in the first visit, but in the first visit, be wary of the fact that from the history in that half an hour, you will know more or less, experience enough, whether there's something else simmering under the surface. And then once your rapport is already there, in the next few sessions, you can directly deal with them and ask them actually even to their face, is there something else going on? Why is it, that this particular treatment is not working for them? Are they really doing the diabetic control? Are they really monitoring? Once you have achieved that rapport and you're cognizant of this, I think they will open up to you, especially if you're women treating a woman. They sense closer, and I think with that and recognizing that women are really great people, walking on that tightrope, and just really have to help them out the tightrope. And I think we will all be very happy then together.
Thank you for that great input. And I will not waste a second more. And I'll move on to the next panel, which is tete-a-tete with our expert nutritionists. So we have Dr. Shefali Bharadwaj as the reporter from Mumbai, and she has special interest to suggest safe and quality nutrition for all, and she combines professionalism with excellent interpersonal skills. Our panelists are Ms. Shilpa Joshi and Ms. Cheryl Salis. They are also from Mumbai. Shilpa is also Vice President of the Indian Dietetic Association. She has trained more than 3,000 educators, and she's Honorary Secretary of the All India Association for the Advancement of Research in Obesity. I'm happy to tell you that we'll be organizing the 15th Conference of Aero in Prayagraj. That will be on a virtual platform. And Ms. Cheryl Salis has a lot of experience with career spanning almost 2 decades in the field of nutrition and metabolic disorders. She's author of several books, including Diet in Diabetes Simplified and Family Guide for Mumbai. So over to you, Dr. Shefali, for this tete-a-tete with expert nutritionists.
Thank you very much, Sarita ma'am, for the introduction. When we talk about women progress, equality, and empowerment, addressing women wellness is an eminent part of it. And so is nutrition an eminent part of wellness. It is an amazing 2 days where women healthcare professionals are talking about women wellness. Today, we will be talking about some myths or some gray areas on women health from menarche to menopause. A very good evening to all and a very, very warm welcome to our dear panelists, Shilpa ma'am and Cheryl ma'am. It is a pleasure to be having a discussion with you today. Let's get started. So we all understand the health benefits of including nuts and oilseeds in our daily life. They are a great source of micronutrients and good fats. Seed cycling is a new thing in talks all over that claims that different oil seeds seem to be impacting different hormones differently. However, there is a lack of evidence, research evidence supporting it. So I would like to ask Shilpa ma'am, what is your experience with this concept of seed cycling when you're managing your PCOS patients? Hello?
Shifali, just start with Cheryl. Sometimes what happens, the net goes off. You could just continue with Cheryl.
Cheryl ma'am, would you like to say something about seed cycling?
See, people do use it in their practice, but however, we don't have enough evidence on using seed cycling. But I know a lot of people and nutritionists who are using seed cycling. But it's very important to remember that we still need to plan a balanced diet because there's a lot of insulin resistance. So we have to focus on, focus on body composition. So more than, looking at the fat, visceral fat, as well as plan a diet which is high in protein and low in fine carbohydrates, as well as seed cycling. When we're doing and we're incorporating seeds, it's very, very important that we have to keep the fat content in check, because typically people go a little overboard with that. So we have to keep that in mind and plan the diet in a way that and definitely focusing on exercise as well. So I think that's a very, very important component of a diet so it's more or less the same diet I would give for somebody with insulin resistance, pre-diabetes or diabetes that we would give. But there is a need for more evidence in terms of, the seed cycling.
Right. I think it's like how you correctly said, whether it's just the seed cycling or is it seed cycling along with dietary and lifestyle modification?
We have to see,
yet.
yes. So we'll need to do a proper study to see whether does seed cycling along with the diet help, or even without the, keeping that as a control, does it help?
That's right. And I think nonetheless, oil seeds are a very good source of all these nutrients that I just
Absolutely.
said. So they must be included. But like how you said correctly, if you are giving oil seeds, control the total fats, because total fats is important.
Absolutely.
So when we come to pregnancy, I'm sure for doctors and for nutritionists, the toughest fight is about the mother-in-law's age-old beliefs. You can't fight it. It's just not allowed. Right. I mean, I'm sorry, I have nothing against traditional practice, but I do have a problem when it comes to non-science-based practices or beliefs. I mean, we all do, right? So I'm not going to say much on this. I want our panelists to speak on the longest standing myth about pregnancy. I guess that when you're pregnant, you have to eat for two. What do you have to say about that?
Absolutely. I think pregnancy, we're not only dealing with the woman who's pregnant, but we're dealing with the entire family. So we're dealing with the mother, the mother-in-law. In fact, the mother-in-law, yes. In fact, recently I had a pregnant woman who came with the mother to the clinic. And she wanted me to buzz because that's where the maximum myths are. And her mother did not allow her to eat banana because she said the baby will slip out. And I almost wanted to fall off my chair because I never heard something like this. So it was the mother-in-law who came with the pregnant woman, and it was the mother who was making the, having so many rules and regulations and what to eat and what not to eat. And again, with pregnancy comes gestational diabetes. So we are seeing an increasing incidence of gestational diabetes in our country. And very important point that you brought out is, eating for two, because people think that when I'm pregnant, this is the time where I can fit into loose clothes and eat what I want. And we eat a lot of carbs. And we know that, in GDM, postprandial blood glucose levels are usually a big challenge for us to manage. And therefore, educating the woman about eating the right quality and quantity of carbs, splitting the meals becomes extremely important. Low glycemic index, low glycemic load foods, making sure we get adequate fiber and protein. And we have to educate the family that you really don't need to eat for two. The guidelines say that you just need to add another additional 350 calories during pregnancy. And definitely we need to improve the protein, because protein content in our Indian diet, especially with people eating very, very low protein, and that is where we need to focus on, along with micronutrients. So very, very important is your calcium, iron, folic acid, all those nutrients. So I think that's usually a big challenge in pregnancy. But however, they are very, very compliant. I think our pregnant women are the most compliant because they know that they have to keep their sugars under control, because it's otherwise going to cause adverse effects.
Yes. Yeah, and I think diet is a very important part because in GDM, controlling the postprandial blood sugars are the biggest challenge, right?
Absolutely.
Right.
I'm
So I
sure
think
Shilpa will also agree with me.
Yeah,
Shilpa's,
I
yeah.
am sorry. I had a slight bit of Wi-Fi issue. I just couldn't get through. It was just, it was not connected. Apologies. Yeah.
so. Ma'am, we were talking about GDM. That there is a very common myth that if you're pregnant, you have to eat for two. And Cheryl ma'am just mentioned that that's a very big problem, especially because there's an increased number in the GDM
Shifali,
cases.
we're losing you actually. I think there's a network issue at your end, Shifali.
Hello?
I can hear her.
Okay, great.
Yeah.
Right. So, Shilpa ma'am, what do you have to add to this? I was actually saying that it's the mother-in-laws, but I think Cheryl ma'am corrected me saying that it's the women also. They want to enjoy this time.
Oh yeah. Well, all women wait for their lifetime once not to think about what they have to eat. Because all our lives we are watching what we eat, and it sort of becomes, they think it like it's their birthright that now that we are pregnant, we don't have to watch what we are eating. And I think the myth lies about what is the right weight gain, because everybody doesn't know what is the right amount of weight to be gained. Therefore they just don't care about how much weight is gained by them, and so they keep eating. And then there is also a lot of, like you rightly said, a lot of pressure from the family to eat more. Like, I have heard so many things. Like Cheryl spoke about banana. I have heard that if a pregnant woman eats a ice cream every day, the child is fair, and Fairchild is like
So
the,
many.
yeah, so many of them. So I have seen women who never ate ice cream eat a scoop every day, and that leads to a lot of weight gain. So it
Right.
sounds, and another thing which is very interesting, which I keep telling people when they come with GDM or normal pregnancy both, that woman is pregnant, she is not terminally ill. She's going to live after 9 months and continue eating. People behave as if these are the 9 months when you're going to eat and then life just ends. So I keep
Right.
telling the family, she's not ill. Pregnancy is I think that is something which has to be understood, because they are sort of overfed and just
Right.
not let any physical activity happen in their life. And that's actually a big challenge.
Yes. So I also think that, I mean, we have set guidelines on how much weight you should be increasing per trimester ideally, and what are the guidelines for the allowance for nutrients for every trimester.
Absolutely.
So I think there's a dire need, that all the healthcare professionals suggest to the pregnant women to go and meet a qualified nutritionist,
Yes.
so they can get rid of all these myths that how much do I need to eat. We're going to tell you how much you need to eat and how do you need to incorporate that in your diet. And I think if mother-in-law is the problem severe, they should take the mother-in-law also for the counseling. And one very important thing I feel is that, during this time when they're eating, they're taking the liberty to eat anything, they should not forget that, once they have a child, the child is going to be the priority. They probably will not have time for themselves. So they should remember that they have to lose so much of
Very,
the
very
weight later, right? So your dietary and
Absolutely.
lifestyle, yes. Yes, so your dietary and
I
lifestyle
think Shifali,
modification.
you rightly said, because we always tell them, because this woman is also going to be more prone to getting diabetes in the future. So what happens is during the gestational diabetes period, they're very, very compliant because they know they have to keep tight glycemic control, etc. But post delivery is when they really don't bother. They actually eat more, because then that's the period where they know that, okay, I'm not going to monitor, I don't need to be worried about my sugars. But
Yes.
then they become frank diabetic in the near future. So I think counseling of this woman during pregnancy is extremely important, that she's at a higher risk of getting diabetes in the future.
And I think they need to be told very clearly and, of course, in very understanding ways that your diet and lifestyle modification can't be part of some yearly planner in some year. It's an everyday thing, right?
Yeah.
So moving forward to the other most attention-seeking topic, weight loss. I think I feel maximum number of myths are here because the myth starts with the word, or the confusion starts with the word itself. People aren't very sure whether they're looking for a weight loss or they're looking for a fat loss. So I often ask my clients, especially women, that what would you rather be, 60 kg on the weighing scale with a 38 inches waist size, or you rather be 65 kgs on the weighing scale with a nice 26 and 28 inches waistline? So no matter how much they want to choose the second option, they just give me a confused stare that, okay, what you said makes sense, but I was thinking weight loss. What has been your experience, Shilpa ma'am, with the clients who come to you?
Yeah, so you're very right that people really cannot distinguish between fat loss and weight loss unless they are told to. And a lot of times, doing just a simple waist circumference, like you rightly said, is very, very important while they go to a dietitian or go to a doctor. It's very, very important. And telling them the problems which are associated with high body fat, especially the fat around the abdominal area. Now, this is also very true in women with lean PCOS. In India, we see a lot of, about 20% of the PCOS women that come to for counseling are lean. So their BMIs are actually below 23, sometimes even 21, 22, but they have all the fat deposited around the abdomen. So, and when they come to a dietitian and when we tell them to go through a fat loss, more specifically, their mothers or typically because these are young girls or their spouses, if they come before they have a baby, or if their gynecologist tells them to go, the worry is that they can't be losing more weight. They look
Yes.
very, very thin. And I think that is something that adiposity as a problem has to be addressed, and has, in fact, before it has to be addressed, it has to be understood. And I think it's a very important thing, especially for Indians to be understood, because Indians, by definition, are defined as lean. I mean, thin fat Indians. So they are thin, but at the same time, they are very adipose.
Right. I like that line, thin fat Indians. Right. So I think another thing that probably needs to be told to them is that they need to do a combination of the ones who want to lose fat. They need to do a combination of cardio and weight training, because your weight training is going to increase your lean mass,
Yes.
and your lean mass is going to actually add up to your metabolism. So it's going to help you burn more calories. Right, people just think that I have to weigh less, but that's not true, and that needs to be told. It's the central obesity that is actually going to predispose them to developing chronic health diseases in the future later. And when we talk about adiposity, the central adiposity and inch loss, ma'am, there's this very hot diet regime, if I may say so, these days. If everybody's talking about it, many are doing it, intermittent fasting. Right, it is associated with inch loss, anti-aging, longevity. There is latest research also saying that intermittent fasting can be used for people with type 2 diabetes and PCOS. But there is a very strong myth associated with it. People ask, can I not eat whatever I want? I'm fasting anyway. So Shilpa ma'am, what's your take on this? How much of intermittent fasting do you follow with your clients, and what are your experiences with them?
So, intermittent fasting is of various kind. So, what I am a very big believer is time restricted feeding,
Right.
so that you don't feed people for 16 hours and then you give them a window of 8 hours to eat. And it has shown very, very good results with everything, with type 2 diabetes, with PCOS, and with weight loss everywhere. But the very important part is what you eat in those 8 hours.
Right.
You can't just let yourself loose and people, collect food. I know so many people who at their work keep one empty lunchbox open on their uh, table, so that whoever eats whatever is kept there, and then they eat everything when they have time to eat. And I think that's something wrong. So within that 8 hours window, it's very, very important to eat a balanced meal. If one wants weight loss and specifically wants fat loss, I think that 8 hour window is the time where you can create a magic. So good quality food there, minimal carbs, good amount of protein, good amount of fiber, plenty of vegetables, fruit, nuts is what should be given in that 8 hour window.
Right. Cheryl, ma'am, what do you have to say about this intermittent
I
fasting?
totally agree with what Shilpa is saying, because it's also the quality of nutrients that the person is eating. And typically they think that 8 hours I can eat what I want, so it's party time that 8 hours. So at the end of it, whatever diet you do, it's still about calorie restriction. You still have to achieve calorie restriction to be able to achieve. And as Shilpa rightly said, adiposity is a problem and not obesity. So I think, changing that whole mindset of people, like, that you don't really have to look at the weighing scale. You could weigh more, but you could have more muscle mass. And Oh, I think that should be the focus. And I think that is what we all focus in our clinic when we are counseling patients, you know.
Yeah.
So I think even when they're doing intermittent fasting, because today there's so much on social media that people just go, you know, they know about it, they've heard about it because celebrities are endorsing it, but they really don't know the right way to do it. And that's why whatever they choose to do, they still need to consult a qualified person and get the right kind of a diet for them.
Yeah, and I think every time, you know, we're eating, it's an opportunity for us to nourish our bodies. I mean, we all do enjoy sometimes, but an overall discipline and overall portion control is very, very important. And also people need to understand that, you know, I'm fasting, okay, 16 hours. There are people who also do 20 hours fasting, which is called the warrior intermittent fasting. Right, but they need to understand that your body is not only about weight loss or fat loss. Your body has so many other basic functions to perform for which they need these nutrients in the balanced amount.
Absolutely. And
sorry, go ahead, Cheryl, go ahead.
So basically, you know, they don't realize, because all that they want to do is fit into that, you know, LBD, as you call it, that little black dress. You know, so they just want to get into that size that they fit into an outfit, but they don't realize that, you know, with the kind of nutritional deficiencies, what's going to be happening to them post 40 and 50. So they really don't have an idea, because right now they're just looking at the present. And that is where our role becomes extremely important, is to tell them to look at the future, because the body you create today is in the future.
That's right.
And I think that is the focus.
Yes.
And I think for people with diabetes or any other health issues, it's very imperative that they go and get their medical regime changed if they are going to follow such diets.
Absolutely.
Yes.
Because we do not know if they are taking a sulfonylurea, or we do not know if what kind of drug they are taking, right? And people just, what Cheryl has been insisting on, meeting a qualified person, that's precisely the reason, is that you cannot, you know, go to Google or WhatsApp, download a diet and just start following. It doesn't work for people. Most of people who will try to follow this will have some metabolic issue most of the time. So I think it's very important that they get it once clarified from a qualified person, and then follow.
Yes, and the doctors also. Absolutely right, for the medication. So
right now recently I had a patient who was on a ketogenic diet. I mean, doing it on his own, hasn't told his doctor, and he's on a sulfonylurea, he's on alpha glucosidase inhibitor, and he's been taking his medications, and he's not even informed his doctor that he's on a ketogenic diet. And then the first thing I told him is, you need to go and speak to your doctor and get your medications revised, and then follow any kind of a diet, because it's very, very important. So a very important point that Shilpa brought.
Yes, exactly. And we've been seeing a lot of women with diabetes in our practice, of course, and India is inching towards being the diabetes capital of the world, and I'm absolutely not proud to say that. And, so there are patients who've clearly understood that my blood sugars are haywire and my diet needs to be controlled. I should not be having sugar in my diet, and they don't have sugar in their diet, which is very good. But the bad part is that they go on replacing the sugar with sugar alternatives like brown sugar, honey, dates, palm sugar, and they feel it's healthy, So what is your experience, Cheryl ma'am, in this with your patients?
I think that's the biggest myth, So at a restaurant, they won't take the white sugar, but they'll take the brown sugar, thinking that brown sugar has got no carbs. And that's another, a myth that we have to bust, is that brown sugar and white sugar are the same carbs. Honey, jaggery, just because it's brown in color, they think anything brown is healthy. And it doesn't have carbs, or it doesn't have calories. So I think that's another thing. So what they do is, instead of having a slice, they'll have an entire kg of cake or whatever sweet is there. And typically we see that during the festival times or birthdays. And today you have a lot of these sugar-free cakes and pastries and all that available. And they will actually end up eating more. So it's the same in terms of calories and carbs. Whether you're using honey, jaggery, brown sugar, it's the same thing. So that's another important point that we need to educate our patients about.
And I think in diabetes, it's also about total calories. It's not just about the sugar.
Absolutely.
Especially the most dangerous ones that I find in my practice are the sugar-free chocolates and the sugar-free Indian mithais. So your sugar has gone out and the fat is super high.
If you look at the label of the sugar-free sweets or chocolates, you will see that the saturated fat content is far higher than the one which is with sugar. And the person will end up eating the entire bar just because it is sugar-free.
That's right.
So that's very important, So I mean, that happens in my house as well. My mom is a diabetic and she also does the same thing. And as they say, ghar ki murgi dal barabar, nothing works.
Yeah, I can
Shefali?
exactly relate with Cheryl ma'am, ghar ki murgi dal barabar. My father knows what I'm saying. So,
Shefali, we have 6 minutes to go, please.
yeah, Shilpa ma'am, I have one question for you. What do you have to say about these sugar-free products that are available in the market?
So I
The
was
diabetes-friendly ones.
Yeah, so I was just coming to that. Reading labels is very important. See, being sugar free and being carbohydrate free are two different things. So, a lot of products, while they are sugar free, they have sorbitol, mannitol added to it to give stickiness. See, every sweet we call a sweet as sweet when it's gooey and sticky. And that stickiness comes out of these polyols. And though polyols cause a very late rise in blood sugar, they definitely cause a rise in blood sugar.
Yes.
It does not go without giving a rise in blood glucose. So it's very important to understand there is high fructose corn syrup, and there are many things which are permitted in sweets or desserts, which are allowed for people with diabetes. Another thing is, like Cheryl said, they may be sugar free, they are not calorie free. A
Absolutely.
lot of times when you eat a regular ice cream, you might eat one scoop and feel very bad about it. But when it is a sugar-free ice cream, you will eat a tub and not even blink your eyelid. And I
Yes.
think that is what is a bigger problem.
Yes.
The psychology plays a bigger impact, I think, than the physiology here, that you are just guilt-free all through.
Yeah. So I think it's very important that we teach our patients to make educated choices, because the doctors and dietitians are not going to be around all the time to tell you what to have, what not to have.
Absolutely.
Another thing with women is that they are always prioritizing others. So they always think that if you have to do something for myself, I have to do something special. But I think as dietitians, we must tell them that you don't need to do anything special for yourself in the kitchen. You can just eat from what you're making for everybody else. Just be careful about few things, right? Now, before we end, because we don't have a lot of time, I want to do this quick rapid fire round with both of you. And there are only 2 rules to this. You have to answer within 2 seconds of me asking you the question, and you have to support your answer with a brief explanation. And no expectations for any gifts will be entertained. I'm sorry, I did not make the second rule.
Shefali, we have just 4 minutes to go.
Yeah, yes, ma'am.
Just 4 minutes to go.
Yes, ma'am. So, Shilpa ma'am, for management of diabetes, which one do you pick? Insulin plant, bitter melon juice, or wheatgrass juice?
None. Because there's no data for anything. So I don't pick anything. I pick a good dietitian and a good doctor.
Right. And Cheryl ma'am, pink salt, kosher salt, black salt, iodized salt.
Whatever color salt, same sodium. So still moderation is key.
Okay. Shilpa ma'am, high protein, low protein, or required protein? Which one for healthy life?
I think protein in the diet is very important, required protein, not high or low. No.
Okay. Cheryl ma'am, for gout, what is your approach? Low protein, no protein, or low purine foods?
I think low purine. I think that's another big myth. You know, I had my sister-in-law recently call me up saying, please give me a list of low protein foods. I said, why? She's saying, no, my doctor said not to eat protein at all. And her uric acid was 5.5. So again, it's that is another thing that we need to, educate our patients about, that we are anyways not eating a high protein diet, So I would say a low purine diet.
Okay.
And fructose, dehydration and alcohol can also cause the uric acid levels to go high. So that is another point to focus.
So Shilpa ma'am, for increasing metabolism, I have a lot of options for you. Green tea, green coffee, black coffee, apple cider vinegar, or lemon and honey water.
Exercise.
Okay, I think that was great.
In fact, I should tell this. Dr. Mohan put up a very nice post. Then in lockdown, I lost 4 kgs off, and then there was written green tea.
Right. I think, yes, I think that answers the question. Okay, so I think that was great. I have a few questions for our chairpersons also. Dr. Mimi, very good evening to you.
We'll address them at the end. Thank you. Over to Shaila now. Shaila is an endocrinologist from Mumbai. It's always a
home to. Now, this is going to be I would say, the last show of this wellness and health program that has been conceptualized by some fantastic women, Madam Tejal Gagan, and has been taken to its logical end by some equally fantastic women.
And so great pleasure to be a part of this meeting. And I was just listening to some of the talks earlier on, and they were so
choice in women who are obese, women who have hypertension, dyslipidemia, hypertriglyceridemia, metabolic syndrome, smokers, etc. So this is in brief the summary about the different estrogen preparations. Well, about the progestins, the most widely used progestins are we use the medroxyprogesterone acetate or the micronized progesterone. Remember, one thing is about progesterone, you need to use the minimum dose used, especially use it in a cyclical fashion so that you minimize the side effects. Well, Arundhati, please continue.
Right, ma'am. So just starting off, taking off from where you ended regarding the side effects, we know that, a lot of people want to use the hormone preparations, but they're very, very concerned about the side effects. In fact, this concept of the side effects of hormone therapy was very prominently portrayed in a book by Seaman, and where she had actually portrayed it in such a fashion that it appeared that whatever was good that was portrayed in The Feminine Forever became equally bad in this book by Seaman. She started talking about breast cancer and stroke and others. And so there, the mad rush with hormone therapy, that kind of stopped there, halted there. So I'll ask Dr. Priya now to talk about the side effects of these hormonal preparations. So the things that we need to be aware of when we are using these preparations, either individually or in combination. Dr. Priya. Can we have Dr. Priya?
You'll have to unmute yourself, Dr. Priya, please.
Unmute yourself.
So I feel very happy to participate in this conversation with endocrinologists and women carers across the world. Whenever we talk about any hormonal therapy, what I realized as a gynecologist and a reproductive medicine person is that menopausal HRT is a very, very small percentage of our prescriptions. It's spanning right from the management of abnormal uterine bleeding to hormonal conditions like PCOS, endometrial hyperplasias, even endometrial cancers. So it's a huge spectrum of use for hormonal medications in gynecology. But the first question that we are asked is, does it have a side effect? And that is a very big problem with compliance, because you prescribe a patient a hormone, but unless you talk to them regarding the side effects, many times they will not take the preparation and end up with more problems. So what I tell my patients is that anything that has an effect will always have a side effect. There is nothing in this world which will have no side effects. Now, the commonest preparations that we are using as gynecologists in younger women is norethistron, usually for abnormal uterine bleeding, for endometrial protection in polycystic ovarian syndrome. And the commonest side effect that I have seen that women experience is bloating and mood changes. Now, mood changes we don't really talk about, but whenever we are giving this hormone for more than 1 or 2 months or 3 months, there is definitely almost 30% of the women who experience depression, who experience negative thoughts when they are on this. So it is very important that in the follow-up visit, commonly in a busy gynec OPD, we just write the hormone and we never hear back from them. It is very important to probe them regarding this. Regarding the estradiol preparations, because I practice mainly reproductive medicine and I have a lot of patients who undergo IVF, the focus in IVF has shifted now to frozen embryo transfers. So almost all the patients, they get frozen embryos. We don't really transfer that much in the fresh cycles. So estrogen is a huge part of our prescription because it is required for endometrial preparation. Now, estrogen, the commonest side effect which we have seen in our clinical practice is a headache. Almost 1/3 of the patients, they will have an experience a headache when they start using it. Luckily, whenever we use the transdermal preparations, the headache is much lower. Regarding the choice of preparation also, if we have an older woman, say 40 and above, we always prefer to use a transdermal preparation because it has got significantly lesser metabolic problems. Although we have a very small proportion of women with liver diseases, but that is something which as gyneks we have to be really careful, because if they have a liver disease, we cannot be giving them oral estradiol valerate. We have to give them a transdermal preparation in the lowest possible dose. Regarding OC pills, I'm sure all of us know that have experienced, there are hardly any side effects, but it is very important that this is a medication where the patient expects zero side effects. So the little bit of nausea and vomiting, which most of the girls will experience when they start oral contraceptive pills, we always make it a point that we write it in the prescription, some antiemetic or something to help her to get over that initially. Other than that, I think most of the preparations have been time tested. They really do not have that many side effects. And if properly counseled, if the patient knows what to expect, then they do really well.
Dr. Priya, would you also be talking about the the concept, the risk of breast cancer? Are your patients worried about it, or are you testing prior to starting initiating therapy, particularly for people who've got to take it for for long periods where we are supplementing the hormone and not just for short periods? So are you getting a mammography or something done beforehand and then going ahead?
Menopausal HRT, unfortunately, it has come under a lot of scrutiny, and most of the women in my practice are not happy to take any form of HRT. The problem, practically, what we face is in older women who are trying to get pregnant. Because now what has happened is that IVF has reached in all different corners of the country, and there are many women who are above 40, above even 45, who contemplate on a pregnancy. Now, in these women, we have to give them 2 or 3 months of HRT to prepare the uterus, and eventually the estradiol has to be continued for up to 3 months in a pregnancy also. So, as a practice, anybody who is over 45, we always at least get a breast ultrasound, if not a mammogram, as a baseline investigation in these women. Because if there is a pre-existing breast lesion, and at least it's although the duration of the treatment is not likely to be more than 6 months, I think it's a good idea. It also is like a screening tool, just like a pap smear. So while we don't prescribe mammograms to everybody, we always do a breast ultrasound before we embark on estrogen therapy in women, especially who are over 45.
Right. So, Dr. Methili, talking about a group where the hormones are started early and they are continued for a very long time, the Turner syndrome people. So, could you please give us an idea about, when to initiate, how to initiate, what is the dose, how do you increase, and what do you monitor? So, I put in a lot of questions for you.
Yeah. Let me start with the induction of puberty in Turners. So the recommendation is that we start hormone therapy between the age of 11 and 12 years and start with the lowest dose possible. The idea of starting with a low dose is that you will take care of the growth potential, and at the same time you will also facilitate a normal pubertal maturation. So the low dose that is chosen is either ethinyl estradiol. Previously, we were using more of ethinyl estradiol, but then of course now the choice is 17 beta estradiol. So we have the estradiol valerate. So an example would be we start with 0.25 milligrams of estradiol valerate, or if you are transdermal, we start with 7 micrograms, or if we are using ethinyl estradiol, we start with 5 micrograms. So this is the starting dose. How do we start? Then, of course, you need to titrate the dose, increase the dose every 3 to 6 months, depending on the patient's response. And finally, you reach the adult dose by 2 to 3 years. So this is how it is started. And then at the end of 3 years, at the end of 2 to 3 years, either there is a withdrawal bleed, or once the adult estrogen dose is reached, we add a progestin, so that, and then the regimen is changed to a cyclical regimen. So the choice is 17 beta estradiol, and of oral versus transdermal, there is an edge for transdermal because it is supposed to promote IGF generation, especially in Turners. Then, of course, once a woman is an adult Turner, they use anything. They use OC pills, they use ERT, they use transdermal. Any of these options are equally good. Then, by and large, hormone therapy in Turner syndrome is not only for reproductive health. Now, in the last few years, what is the data showing is that there is a reduction in the endocrine and metabolic events. So people who have taken hormone therapy, Turners with hormone therapy, had reduced morbidity. They had reduced endocrine and metabolic disorders like hypertension, IgT, dyslipidemia, and then autoimmune diseases, even thyroid diseases. So this is to say that hormone therapy in Turners is reducing the morbidity. And then the concern about venous thrombosis in Turner is also negated by the observational studies. And then, so these are all, this is the summary of, a brief summary of how you start hormone therapy and how you continue. Usually it is to be continued till the age of 45 to 50 years.
Right, ma'am, right. Going on to another section where we do use hormone therapy, Dr. Priya, this is for you, PCO. So, we'd like to talk about your use in PCO patients. How long? What is the endpoint? Starting off, we start off with a lot of patients, and then there's this question about till what time? What are we looking at? So, could we have your opinion on that?
Arundhati, I'm sorry for playing bad cop, but we have around 7-8 minutes left.
Right. Yeah. Right.
To be very quick, the only indications where I would prefer to put a woman with PCOS on hormone is three. The first one is a young girl who is bothered by amenorrhea. Now, in this subset also, at least in my practice, I always started after the age of 18 because I'm not very comfortable giving younger girls oral contraceptive pills. The second indication where we would like to give them hormones is a woman in the reproductive age group who has infrequent periods. So if she has less than 5 cycles in a year, for endometrial protection, she needs to be either on an intermittent progesterone or she needs to be on an oral contraceptive pill. The third indication, which is very commonly used, that is if the woman has an abnormal hair growth, if she has hirsutism. And unfortunately, the practice in India is to give a cyproterone containing OC pill. I think it is very important that all of us understand that it is a cyproterone acetate containing oral contraceptive pill has a much higher risk of venous thromboembolism. It is not even approved in most countries for this use. So for these subgroup of women also, I think it is very important that we give them a low dose oral contraceptive pill, maybe an Overall or a Novolon, and not be in a hurry to start a cyproterone acetate containing pill because the side effects could be catastrophic, although it would be for a very small percentage of girls.
Right, ma'am. And so some quick answers there. Dr. Mithili, the inevitable, the postmenopausal, which preparation would you choose and how long would you go? And also the POI, if you could just answer that very quickly.
There are only two indications for hormone therapy in menopause. Number one is the vasomotor symptoms, and second is the genitourinary syndrome. Well, the amount of estrogen that is necessary to alleviate hot flashes and then to protect the bone in a postmenopausal woman is very less. So what you do is you start with a very low dose. If you are using again transdermal, you start with 14 micrograms. If you are using a estradiol, the valerate, you start with just 0.5 milligrams. So the starting dose is very less. Remember, then the second thing is one size doesn't fit all. Well, you look at the response and then you may slightly increase the dose. So by and large, any estrogen can be chosen, whether it is conjugated or ethinyl estradiol. But then what is important is the lowest dose that is needed to be chosen. Adding a progestin, of course, in a woman with uterus, again, as Dr. Priya mentioned, keep in mind the different problems of progestin and then use the lowest dose possible, either cyclically or a combined low dose. Finally, POI differs from menopause in that you need to give a standard dose in POI, like an OC pill or a standard dose of ERT. But then, and finally, over years in POI, you can reduce the dose of hormone therapy. So the message about menopause is that you need to use the right dose and then for the appropriate time, depending on the woman's needs.
Yeah, not feminine forever, but feminine as feminine should be. Right. So the last question there from my end for Dr. Priya. Any difference in
I need to interfere. Can I just talk to Dr. Iraqi a little, Professor Iraqi, so that we have a universal opinion and then go back to questions in case we have time, please?
Yes, certainly.
Yeah, thank you. Thanks. I mean, since we have the last 5 minutes left, otherwise Tejal is going to really knock me off this program.
Oh God, you guys are making me sound like Hitler.
Not at all. Not at all.
So, Iraqi, first of all, a very, very personal, warm welcome. We are really privileged and happy to have you share the same forum with us. And I had two very quick questions for you. First of all, I wanted to understand, okay, does the scenario in Morocco differ in any way from the scenario in India, what our esteemed panelists have been putting across? And what would your take-home message be? What would you feel are the take-home points which our audience should really remember when they're thinking in terms of prescribing hormonal therapy across the spectrum, be it in a premature ovarian failure, be it in menopause, or be it in PCOD, please?
Thank you very much, and very good evening for all from Morocco. And thank you for this invitation because it's a very particular webinar education done exclusively by women and even superwomen. So,
Superwoman, yes.
thank you for the questions. In Morocco, we are very concerned with the weight gain because, for example, when we spoke about estrogen, and I was very interested by the diet in the first section. Moroccans from the south, they like fat women. If you are not fat, it's difficult for you to be married. So when, for example, we prescribe estrogens from women, then you are in the south, it's okay. But if you are in the north, people would like not to have weight gain. So I think it's very important and it's difficult in our prescription. And for the take-home message, I really would like to emphasize that the hormonal therapy is not always for menopause. It's very important to understand that there is a huge spectrum of use and focus, as the first doctor says, should be on the estrogen, especially transdermal estrogen. And the side effects are known, but we should educate people about the side effects because women should know that they may have depression, headache, and even weight gain, as we say. And then please always use the minimum dose of progesterone. It's very important to have this. And it would be interesting to have a breast ultrasound and mammogram for women due to the risk of breast cancer. Here in Morocco, the Turner syndrome is also treated by the same way. And before we couldn't have for free growth hormone therapy. Now it is for free for all the women. So it's very interesting because we are a poor country. It's very expensive to pay that. And the treatment starts at the same year. It's between 11 and 13. And I like the indication of treatment of PCOS, young women with amenorrhea, endometrial protection and hirsutism, and also that hormonal therapy replacement should be done in some, but not all women with menopause. Thank you very much.
Thank you. Thank you. That was really comprehensive. And that was really appreciating it all the way from Morocco. Arundhati, I can give you last 1 minute for your last burning question.
So rather than the question, I think let's put it up as a concluding statement from my end.
Okay.
Because I was about to ask Dr. Priya about hypo, and is there any difference? But since 1 minute, it might be difficult. So basically what we've understood is that we really need to understand the hormones better, not just estrogen and progesterone, each in its individual capacity. Not every hormonal supplementation is for everybody, as Dr. Mithil and Dr. Priya very correctly pointed out. There are some mispractices going on, like Dr. Priya did point out, or cyproterone and all, which have been, very rampantly practiced, and those need to be changed with our better understanding of these hormones. So I think concept of feminine forever with the bell ringing is is here to say. We are all, we are all going to be feminine forever, but then in the correct way. We need not barge into any kind of therapy. We should just place the therapy as and when they are needed, for as long as they are needed.
I totally agree with you, Arundhati. That was a fantastic conclusion. And I think, to be very honest, women are beautiful right from womb to tomb. So, I mean, as long as we're making the right choice as far as therapy is concerned, I think that is really good enough for all of us. A big thank you to all of you all out there. That was a fantastic presentation. And I know a lot of hard work has gone into it. Thank you, really appreciate it.
Thank you. Thank you.
And coming to the next session, very interesting session, communication. Communication by itself, I think, is an art rather than a science. And I don't think communication matters in medicine only as far as diabetes goes. I think it is actually the heart of the art of medicine. Because unless you communicate well, unless you work on that interpersonal relationship, things are just not going to be the way they ought to be. And to take this forward, we have none other than Dr. Nilakshi Dekha, who's a consultant endocrinologist at Apollo Hospital, Guwahati, again a recipient of a number of awards. Chitra out there, Associate Professor Endocrinology, MS Ramya Medical College, Bangalore, again recipient of a number of awards, and Tejal. I mean, it feels like an irony if I have to introduce Tejal, to be very honest.
After all of you badmouthed me the whole day yesterday and today.
But all the same, she's an endocrinologist, a gold medalist, lots of feathers to her cap, including this lovely meeting. So I don't think I need to say more than that. Please, it's all over to the three of you all.
So, a very good evening, everyone. As we are arching high in the trajectory of scientific discussions, we had 2 full days of scientific discussions here and there. We now drift a little into a domain which is less frequently discussed in scientific discussions, scientific conferences, and Dr. Tejal and Dr. Chitra, who have worked in communication and diabetes, they will help us take a sneak peek into what is called communication and diabetes. Now, when we speak about communication in diabetes, that is an intriguing topic. And I would like to ask Dr. Tejal, what do you exactly mean by communication in diabetes? Because that's a vast term. So what do you mean? How do you, actually do you mean by communication in diabetes?
Thanks, Nilakshi, for that question. So I'll be very clear that what communication I'm alluding to is the communication which occurs between a doctor and patient in the clinic for diabetes in an outpatient.
अरे मोना सुन ना, अभी तो शांति
We're
रख
talking
थोड़ा,
not
1-2 दिन
about
है ना.
Priya, can you mute yourself, please?
So when I'm talking about communication, I'm talking about the communication which occurs between a doctor and patient in the clinic, in an outpatient clinic. And it includes the words, the phrases, the sentences that a doctor uses when they talk to a patient. But over and above that, it also includes the tone of voice the doctor uses, whether the doctor makes eye contact with the patient, whether the doctor smiles at the patient, addresses them by their name, what is the body language of the patient. So it is basically the communication between a doctor and patient, but both verbal as well as non-verbal. And Dr. Chitra and I are very passionate about this. So what we actually did, Nilakshi, is we conducted a series of focus group discussions. We plan to do 5, 2 of which we've completed, where we invited patients of type 2 diabetes, about 10 to 12 of them in one setting. And we asked them about what the words and phrases that the doctor uses that they like, what were the words and phrases that they did not like, and how would they have liked the doctor to talk to them. So basically, I think that
that is quite interesting. When you're saying those things, it's quite interesting because this is we hardly discuss this, or we never introspect ourselves as regards how we are communicating with patients. So what did you learn from that focus group discussion which you carried out?
So I have to confess that Chitra and I were shattered when we read the transcript of the focus group discussion. I'm being very honest. Our patients were upset. They were angry. They were frustrated with the way we communicated with them. And a lot of them had lost hope that anything is ever going to change in the way we communicate with them. Now, please let me be very clear that I'm not blaming the doctors in any way, because we all know that, at least in India, communication skills, how to explain to a patient about their diabetes, is not part of the medical curriculum. And if you could ask me, Nilakshi, one point that I could take away, it was a huge FGD. There were many themes that emerged. So I'll give you just one example. So the most common way that we caution patients about their diabetes is we use scare tactics. You know, Mr. XYZ, if you don't control your diabetes, your kidney will get spoiled, your heart will get spoiled, your nerves will get affected, you may even go blind. This is normally the way that, including me, we all are guilty of talking to our patients. So we asked patients, how would they like to be communicated? How would they have liked to have this rephrased? And what patients said is they always wanted positive communication. They wanted to feel hope. So let me just rephrase the same thing. And let me tell you that over the past few weeks, I have been practicing doing this in my OPD. So instead of that, I could have said that, you know what, Mr. XYZ, if you control your blood sugars really well, then you can have a life which is normal, healthy, and completely free of complications. Let's work together to ensure that you remain free of complications. So when you give hope to a patient, they're more likely to listen to you. And if you talk in a negative manner, it's likely to affect them in a negative manner.
So you kind of empathize with them.
Yeah.
You try to address them at a place where they are actually, and then try to positively pull them forward in the journey of management of
Care they'll be
diabetes.
dead, that you'll be blind tomorrow. That's all.
Yeah. Dr. Chitra, what was your experience in Bangalore? Like you had a different patient cohort, which was demographically different from what Dr. Tejal had in Mumbai. So was your experience a little different from what Tejal had? What was the kind of response you had, or what was your uh, learning point from the focus group discussion?
Thanks, Dr. Nilakshi, for that question. Yes, the crowd who participated in the focus group discussion
I
in
think Chitra, you should speak a little louder. You are not very clearly audible.
the audience who participated in the focus group discussion in Bangalore was slightly different. They were younger, a more urban crowd, and English speaking crowd, and very articulate crowd. And so at the end of the focus group discussion, when I was listening to the transcript, I couldn't get past 15 minutes per day because it was heartbreaking. In fact, I thought most of the data which we get from FGD is going to be ego massaging, make me feel good, and say,
oh yeah,
page is wonderful. At least we thought at least some percentage of it would be that. But we were quite shocked to learn that even some of the most articulate patients, we were doing things which was causing them hurt, right?
Okay.
I'll give you, for example, since this was a very young crowd and they had diabetes, we always have conversations about pregnancy, right? We all understand how important it is to prepare for a pregnancy,
right?
And we say that with that intention, right? But one girl particularly has been thinking about not having a pregnancy because we've told her so much and scared her so much about how managing diabetes during pregnancy is going to be a great ordeal, and the fact that the child that she has could be at increased risk for diabetes. And her thoughts were, why would I want to do that to a child? Why would I want to move? So the intention of the doctors, in this particular instance was me, was to make sure that she had a healthy and a safe pregnancy even before planning. But the effect it had on the patient was completely different. I was deterring her from doing something which she was aspiring to in her life, and having a progeny is something which every young person has or does. So there were some astonishing things that we learned, and we're in the process of analyzing all our findings and putting it all together. It has been eye-opening for both Tejal and me and the team that we're working with.
So that is quite nice to hear that certain things, intricate aspects or illusionary aspects, which we tend to miss in our day-to-day communication with patients, has really surfaced from the focus group discussions which you carried out. So, Dr. Chitra, you said about the patient's perspective, how they view what unknowingly, like no doctor would actually knowingly hurt a patient, but it is, of course, because of the kind of routine or monotony which we have in our day-to-day practice. So we tend to behave that way unknowingly, and that hurts the patients. We tend to become more judgmental kind of a thing, what appears from your this thing. So have you tried to find out what is the how doctors feel about the communication skills? Like, have you found out if doctors really introspect about their communication skills? Do they try to find out from like, we can always take an anonymous feedback from patients and then find out about our communication skills in our chamber. So have you tried to find out the doctor's perspective on this?
Yes. So somewhere when we were going with the analysis of the data which we got from the patient side of the story, we began to wonder that when we set out to become doctors, or when we sit down in our OPD to meet our patients with diabetes, we do not intend to cause so much of hurt to patients at all. That's not anybody's intention at all. But still, there's hurt being experienced on the other side. So I thought it was important to tell the side of the doctor's tale as well. So we designed a survey. Have you taken the survey, Dr. Nilakshi?
Don't plug the survey here, Chitra.
Yes, I did.
So we did a Google survey now that we are all stuck in our own homes with, so it was good. It worked well for us. People were open to answering an online survey. And it was quite elaborate to try and understand if we've paused to think about it, right? So nobody during our entire DM or any course that we did to train ourselves to take care of individuals with diabetes ever spoke about the need to talk to a patient, to to talk about coping. How are you doing? How are you able to juggle your exercise in your daily routine? You have 2 kids. Do you get the time to plan your meal through the day? We never ask how we are coping, right? It's
Right.
another project which has been dumped on your patient, and they didn't ask for it, but it's part of their life now. So when we spoke to doctors, it was eye-opening in that the intention was always right, but the tools and techniques of communications were not really presented as an option. And in our busy lives, we're so busy trying to finish work quickly that we don't pause to think about the effect that our words and nonverbal communications have on our patients. So this has been a completely eye-opening learning experience for all of this, and we want some of these findings to be distilled out to all of us, so the experience that our patients have when they come for their care of diabetes becomes better. That's the overall intention. Tejal, do you want to add anything?
I just wanted to say one thing, that the fact that we as doctors never acknowledge that managing diabetes is difficult. Do we ever say to our patient that, Mr. XYZ, I know that this is really tough. I know that taking insulin is really tough, but I really wish you would keep taking it so that, your health is better. So I think just the need to acknowledge and validate the person, that one sentence makes all the difference between the patient complying with your treatment and saying that this is a rubbish doctor, I don't ever want to go back to him again or her again.
So yes, so what appears like from this discussion is that when we are speaking about communication in diabetes, it is mostly a stereotypical practice which we all have, where it is a patient sitting opposite to us in a table. We give them a prescription and certain do's and don'ts, irrespective of being empathetic with them to actually find out of like in what position they are, whether they'll be able to carry this out, or we should, rather than giving them the do's and don'ts, we should actually be helping them out with ways and means by which they can achieve those targets, like showing them light at the end of the tunnel, that there's hope, and this is the way that you should follow to actually reach that. So I would like to ask both of you, like from the focus group discussion which you have, do you have something like which you have to give to the clinicians or practitioners like us that would enlighten us in our ways and means of communicating with our patients in henceforth, like from now on, after listening to the negative feedback from the patients regarding our communication skills, we fully understand humbly that we need to rectify ourselves. So could you suggest us some ready to go tools, ways and means by which we can, include them in our clinical practice and make the communication a two-way exercise rather than it being a one-way exercise, So Tejal, you can give us some points, and then Chitra will also give us a few points, because you two have extensively studied in this. I hope you must be having some take-home messages
for
I have us.
One clear message. So I will put it in the words of one of my patients, Jennifer. And she said, when you go to the doctor with the HbA1c report, and if your report is high, it means that you are a useless person, and the doctor equates the HbA1c report with your character. So that is heartbreaking. That is heartbreaking to know. And what happens is, most of the times doctors come across as judgmental. The minute the HbA1c is high, then we say, did you do your diet properly? Did you exercise properly? Are you taking your medications properly? So the message that goes across to the patient is, one, that I've been bad and the doctor has judged me as lacking. And somehow the way we ask the questions makes them feel that we are blaming them for the poor control of HbA1c. See, if a patient wants to be judged, like a woman wants to be judged, she'll ask her mother-in-law about her, or she'll ask the Bajuwali auntie, or she will ask her neighbors and society at large if she wants to be judged. But when she comes into your cabin, she comes to you with trust. She comes to you for reassurance, for guidance, and for her to show you the way. And the only reason the patient is sitting across from you is because they care about their disease. If they didn't care about their disease, they wouldn't come at all. So one thing we all need to change in our daily practice is be less judgmental, not blame the patient for the inadequate control, but it should be a partnership where both of us acknowledge our shortcomings and then we find the way forward.
Very well said, Dr.
Chitra, do
Tejal.
you have any message?
Yes. I think for us to give tools would be for us to sit on a pedestal and give a sermon out. That's not the way this is to be done. I think what we are calling for is more awareness and sensitivity towards your patient, and probably introspection towards your own actions and words.
Right.
That's all. Like, for example, Tejal and I were having a conversation this morning. If it were your friend who walked into your cabin with diabetes, right? And if they just got diagnosed with diabetes, the first word you would want to say is, it's okay, we're going to take care of this. But somehow we don't seem to say that to our patients, right? Probably we don't need to cross all the borders off between doctors and patients, but maybe it's important to just reach out a little bit within the bounds yet to let them know that, you know what, we got this, we're in this together, I got your back. So there's nobody in their life to tell them that. And I think the burden of diabetes care resides in that exact point. So if everybody in the audience now goes back and thinks about what I said, watches for the patient's change in expression or their change in body language in response to our words and actions, that will be a win for all of us.
Yeah. Well said, Chitra.
Yeah, true, very true. So, so from this focus group discussions, from which both of you had in your clinics, what transpires from what you have spoken is that we as doctors need to introspect into our communication skills, because we may be good in clinical practice, but that does not mean that we are good in communicating as well. So that is an art which we should start imbibing or start improving in today's time, especially today's time, because we cannot in today's time just dismiss a patient. Those days where we could do that in maybe 15, 20 years from now, times have changed, patients have become more aware. And the very fact which Tejal said, that the patient coming to you as an endocrinologist or as a practicing physician itself proves that he's keen on improving his diabetic status, he's keen on improving his health. So what we as doctors, we should do is two things. First is optimism, give them the hope that there is a treatment for diabetes and that they are in safe hands, which can be taken care of. We should help them, give them ideas by which they can achieve their glycemic goals, as well as a comprehensive management of diabetes and its comorbidities. Second thing is the reassurance that when you are always there to take care, and there are certain ways and means which if they do, then collectively we can make conquering diabetes a reality rather than a myth. So it will be possible to conquer diabetes more as a group. And the most important thing is, I think, introspection, that we should really keep ourselves in the shoes of the patients, think the way they are, like they're already scared when they come into our chamber visiting, but their will is there. They have the will to get well. They have a will to take care of the health. That itself is proved by the fact that they are coming to a hospital to meet us or to take treatment for us. So over to you, Dr. Sehla.
Thank you. Thanks, Nilakshi. That was an eye-opening discussion, actually, to be very honest. You know, there were two very pertinent statements which came across. One, yes, I am really glad to hear that as doctors, the intention is right. So it is not that the intention does not exist. I think to some extent, to be very honest, we are all very overburdened. And sometimes that burden can become a little, I mean, I would say the pressure sometimes build up so much that as doctors, we may not have the insight that we are not behaving the way we are supposed to behave as far as our communication is concerned. Because another very important statement that both of y'all, Chitra and Tejal, made was that, you know, as far as, I mean, we have not been trained to communicate. I mean, there's no syllabus which says, how do you communicate? I mean, how do you talk? There are no bedside manners taught to us. And in our hospitals,
there are no guidelines. There are no guidelines.
And where we are trained, I mean, if you get 4 hours of sleep, you're blessed. I mean, it's a great day if you've slept for 4 hours. So, you know, there are lots of, I mean, but I am really glad you did this, because I think we'll all go back with a little more insight. And I definitely want to know how it works out in Morocco. with Dr. Iraqi giving us some insight about how efficient or how human is the communication out there, how overburdened or underburdened is the medical system.
Very much. It was very, very interesting. And I think communication is the key when treating patients with diabetes. It's the real key. Here in Morocco, we have some problems because we are educated in French and we speak in Arabic with people. And sometimes it's not the same meanings, you know. So.
Right.
And we have also other examples. For example, when we explain the pathophysiology, we cannot say that the beta cells are destroyed because Moroccans, they can't stand having a death cell or the death organ inside their body. So they feel like they are going to die at the same time they are going to be.
Yes.
So the words are very powerful, and they have the power to elevate or to destroy people. So we have to learn from psychologists and to learn education, and the communication is very important in this context. We also have difficulties with Muslims because when you speak about honey or dates, and you say you cannot have a large amount of dates or honey is very sugared, then they feel that if you don't understand them, so we have to find the right words to educate them. And we also have tools in Arabic. It's not tools in French because they speak in Arabic. Thank you very much.
That was fantastic. I totally agree with ma'am on that count, because honey and dates have got a religious connotation to it. So anybody who tell them, so I've learned the hard way to tell them, you can have maybe a drop or 2 drops of honey and maybe have 1 date as a mid-meal snack to sort of overcome that inhibition. Because the moment otherwise you can go directly on confrontation path, and that is the worst part to take with your patient. Thank you very much, ma'am. Thanks. That was really great. I mean, Tejal and Chitra have stuck to what they have said. Yes, we still have 5 minutes of discussion.
Audience questions. Stella, you want to take some audience questions?
I think we should. I think it would only be fair if I could have everybody who's still with us, I mean, put on their video cams so that, I can address the questions. I understand who's actually there. Okay, so since I can see Shilpa, Dr. Meenakshi Kure has a question for you. She's from Nerul, Navi Mumbai. And she has asked you that what is your impression about corn syrup? She wants to know about corn syrup from you.
Yeah, so corn syrup, corn syrup is high fructose corn syrup. And corn syrup, in what sense? In diabetes?
In diabetes.
Yeah, so corn syrup is known to increase blood sugars, but more than blood sugars, it is known to increase triglycerides. And triglycerides is a huge problem in patients with diabetes or even with pre-diabetes, and that is why products containing high fructose corn syrup should be avoided.
Okay.
And can I add to that? Yeah. High fructose corn syrup is also considered to be one of the important factors which is reportedly responsible for the high prevalence of non-alcoholic fatty liver disease and liver cirrhosis. Yeah. So the gastroenterologists, they've actually worked out that it is mostly because of that content in various beverages or various food which have this as an artificial sweetener, which is responsible for the increasing exponential increase in liver cirrhosis in patients. Yes. Not only diabetic patients, but overall.
Okay. Arundhati, there's a question for you from Dr. Snehalata again. That is there any preventive steps so that hormonal balance can be sustained and you can look as good as you always?
Please give us that tips also.
And Dr. Mimi Giri for her lovely skin.
Yeah, I'm going to ask Dr. Mimi that also.
Oh my God, I was happy that I could unmute myself. I mean, well, not really. I mean, not really. But I guess it's all about lifestyle, isn't it? I mean, staying fresh, staying healthy. It's all about lifestyle. You do see a lot of patients, people, not patients, women taking menopause very poorly. They have all those symptoms, and you take it very, and then you have others who take it very gracefully. They do not have that many symptoms, and you do see people who are more fit kind of, not going into those kind of very severe attacks of postmenopausal stress. So I guess it's all about healthy living from the very beginning. I would also like the opinion of the others, because otherwise I wouldn't have an answer to that apart from healthy living and staying fit otherwise.
Dr. Vivian and Dr. Mimi, you all want to add something to that, please?
I think it's more of a complex interaction. I mean, certainly the healthier you are, you're going to go healthier into menopause. But that's also, with the way people handle chronic illnesses, it's the same thing. It's throughout. There's no double standard. It's a complex interplay of nature and nurture. How's your personality? That would, tell you how this person will handle chronic stress, chronic diseases, as well as menopause. And at the same time, it's how your friends handle it. How do you see your family handle it? So that is, again, that's the nature component, the nurture component. So nature and nurture has this very fascinating interplay for me to see how they handle it. And one interesting thing is those people who handle postmenopausal symptoms, people who have premenstrual tension. I find that, I don't know what the other panelists think, the higher risk of you having premenstrual tension, that would then sort of educate me with a risk factor of having menopausal symptoms. I mean, what does the panel think? Again, I mean, I feel it's a complex interplay because of the way they handle those issues.
Dr. Mimi, you want to add something to this?
Well, I was just going to say what she said, but I just want to add about premenstrual syndrome and high risk for menopausal syndrome, menopausal complaints. I actually find that women who have, absolutely a premenstrual syndrome tend to have a badder menopause, I find, or worse menopause with incredible symptoms like more than anything, it's actually the mental stress. And it's not only the flushes, but they feel that they cannot cope with life and they don't know what to do because basically they feel that the life has ended. So basically it's like they're no longer a part of society and they cannot contribute to the society. I think that this is something that we need to take seriously because especially in Nepal, that we do have higher rates of suicide after the age of 45 in women than actually, I mean, we have a peak from 15 to 34 and then 34 to 45, they're okay. And then after 45, they seem to be worse. So to me, I think that menopause and dealing with menopause as women, we should empathize and also try to help them in the best possible way, whether it is hormone replacement therapy, counseling, referring, or basically understanding. So that's my theory. So, and yes, I do associate premenstrual syndrome with worse menopause.
Is menopause associated with aging? I mean, it's like the moment a woman gets menopause, she feels, oh, I've really become old. Is that the main component to it?
But I think that, like, I don't know, especially in Nepal, the woman is central to a lot of the household, absolutely, when it comes to their prayers, puja, and things like that, And when it seems that they become menopausal, they feel sidelined, unless you're a very bossy mother-in-law. We go back to the mother-in-law always. Do you know that they say that behind every successful man, there is a very surprised mother-in-law? So basically, we seem to keep going back to their mother-in-law. And I always tell every patient who is a daughter-in-law, don't forget your future is a mother-in-law. So try to be empathic and make sure that you don't make your daughter-in-law go through the same things as you went through with your mother-in-law. So I think that the mother-in-laws begin to feel that they are threatened in their role in the household when they suddenly become menopausal because the daughter-in-law will take over everything. So
okay.
I think it's that, yeah.
Okay. Tejal, somebody's asked you that somebody means Dr. Meenakshi has asked me that how do you counsel diabetic patients on cutting or lowering rice or sugar intake for lifetime positively? I mean, how do you manage to give them dietary advice very, very positively?
Shefali, do you want to talk about rice and personalized nutritional intervention?
Yes, I think how we do that is that, we have a program which is AGM-based diabetes lifestyle management program, where we ask our patients to maintain a food diary for first 14 days. and we integrate their food diary with the reports that we get, and we actually show them if their blood sugars are going high with rice or no. There are people with who the blood sugars have not gone high with rice, so we probably will not tell them to completely cut out on rice. There are people whose blood sugars have gone high with the wheat, so for them, yes, of course, wheat needs to be replaced. So I think just telling them cut out on the rice part or the sugar part, it's better that we have a proof for them, because we've had clients who one of my clients, I remember, her blood sugars would just shoot up with khichdi. So the coach didn't have to tell her, don't have khichdi. So khichdi is a rice and a pulse combination preparation made in India, and she herself said, I'm not going to eat khichdi because I know my blood sugar goes high with it. So that is the kind of impact these kind of programs have. So I think that's what this is the way I think in which we can handle these questions, or tell those people, that give them a proof of how your food and how your food habits are affecting you. So then I don't think then there needs to be a positive affirmation or a positive emphasis from the doctor side. It's the patient who himself sees and says, okay, this is not good for me. And then we have coaches. We have our coaches who are masters in nutrition and dietetics, and all are certified diabetes educators. So they are always giving them better options to this. So it's not that they're going to miss out on anything. It's just that, they have a proof and they themselves make wise and educated choices.
Shefali, probably, there is some patients, when they eat 2 idlis, the sugar doesn't shoot. The minute they eat the third or the fourth idli, the sugar shoots up. So
Yes.
not only rice versus wheat can be clarified, but I also think portions. And when, you can ask them to try it out, and you don't even need a CGMS for that or an AGM, even with a glucometer. So I'll tell you my own experience. My father-in-law, when he eats 2 idlis, so for the foreign faculty, idlis are steamed rice, kind of small cakes, and but not sweet. And when he eats 2, the sugar is good. The minute he eats 3 or 4, the sugar shoots up. So now he himself has done portion control by checking his blood sugars and seeing the relation of the food with the glycemic excursion.
That's right.
That's Vaishali and Tejal. That is a very, very wise observation, because that's what I tell my patients because everybody metabolically is unique, isn't it? So you have to test yourself. See, some people walk in with a sugar of 400. I said, what did you just have? Banana. And like some people say, look, I have a banana and nothing happens. So these are very different individual responses. I agree with you entirely. It's very important to know what your system, how it behaves towards a particular diet. I'm sorry, I said, let me get in on my phone only. I tried everything, and then I'm really sorry. Then I just changed the broadband as well. Everything I changed.
I mean, it's all not at all, ma'am. No problem. Vaishali, there's a question for you. Dr. Pooja wants to know that in a female patient, when she tends to internalize so much of her trauma, how would you really diagnose depression? I mean, what are the cue points which you would think that, okay, maybe there's something more to this?
Yeah, I think we just interrupted Dr. Aarti at this question. That was my last question.
Sorry.
I think, Dr. Aarti, if you're with us, can you just answer what are the
Aarti, then the question is directed to you. Very sorry, I didn't know this.
Yeah, I'm so sorry I interrupted you at the end because of lack of time.
It was a perfect answer, take-home message from her. I think she should repeat those 2 questions, which we take only 20 seconds. That's it. 1/3 of a minute.
Yes, ma'am. Yeah, I'm here. Like I said, depression is a syndromal entity. There's no one thing, like, in your diabetes, you have blood sugar being high and you diagnose a patient with diabetes. In depression, we need to have this conglomerate of symptoms being together. And we need to fulfill the criteria at least for 2 weeks. Now, on an everyday basis, generally, we have these mood swings in which, we feel upset, or, a day something has gone wrong at work or at home and we feel down. That is not depression. That is just normal sadness, and we should take it up like that. I mean, it's a normal event in our life. But depression is diagnosed only when there is sadness lasting for 2 weeks at a stretch, and it pervades, like I said, it infects your entire life. It boils down, to something that you don't enjoy life at all. So there's anhedonia, wherein you don't seek pleasure in anything that you do, or, things which were giving you a lot of interest earlier don't seem to be pleasurable enough. And there's anergia. Anergia is something in which the patient feels lack of energy or fatigue at doing the smallest of things. The patient feels like crying all the time. They may have feelings of worthlessness, hopelessness, helplessness, feeling suicidal, having death wish, having sleep and appetite disturbances. So any two of the major criteria and any three of the minor criteria, if they are fulfilled, then the patient has depression. We diagnose it that way.
Okay.
So we stick to our ICD-10 guidelines.
Since you're already talking, I saw in your CV that you were interested in OCD as well.
Yes,
so what do you think women have more of OCD as compared to men, and what do you do about like exactly what you said? This day-to-day things that bog us down is not depression.
Absolutely.
And some people are very particular about some. So there's a very fine line between this OCD and, you know, like being meticulous.
Correct.
So somebody can say you're very meticulous, but somebody says, good God, she has OCD.
Right.
Yeah.
Now, OCD is common, ma'am, equally both in men and women. But the kind of OCDs that we observe in the two genders is different. So we see more of this contamination kind of OCD, wherein they go on washing their hands and, you know, cleaning and, you know, meticulously keeping things in place, or scrubbing the floor several times, or washing the vegetables several times, or taking, you know, 2 hours to take a bath or wash clothes. That is the kind of OCD that's seen generally in women. Men have a different kind of OCD, like checking locks, or, you know, checking the cash that they give, or, you know, counting things again and again in their mind, or getting, you know, obsessive thoughts when they are praying to God, some negative kind of thoughts they get. So there's a difference between the symptoms in OCD, but it's just that, you know, it's common both ways. Like you said, ma'am, there are many patients who are very, very meticulous, and you must be coming across them, you know, when you see so many patients in your OPD. Now, those are the characteristics of an OCPD. That's an obsessive compulsive personality disorder, or an unencased personality. And this kind of personality is very common if you can identify it in the school teachers, in headmasters of school. They're extremely meticulous. They don't want things to go out of their hand. They're workaholics. They'll give up all kinds of pleasure in life, but they would want to stick on to their work and complete it to the finest thing. So they'll be very good workers, but personally they'll always feel lonely and dejected, because, you know, they always feel that the work is not finished still.
What about the disease? Coping with disease and diabetes from that perspective, metabolic diseases, are they better controlled because they are very much perturbed about it, or they take more care?
Ma'am, they take very good care of their illness, but anxiety weighs down heavily on them. I mean, even a blood sugar level of say 145 would bog them down. They would come running to the endocrinologist, asking for an appointment, begging for an appointment rather. You can see them. Probably their charts will be very, very well maintained. So you'll be very happy with such patients. You know, to have such patients is like a blessing in disguise for you people. But they are so bothered about their illness sometimes that, you know, they don't tend to pay attention to relaxing in life, to enjoying the small things in life. All the time, they're just obsessed about the illness and how to take care of it. Each portion size, you know, they were just talking about portion size, and I was thinking about my OCPDs. So each portion size, you know, will be limited to only that much, and not a grain of rice extra they would want to add in their meal. They're extremely meticulous, but it bogs them down heavily, you know, emotionally.
I had, in the interest of
very, very, very well said. Very well said.
In the interest of time, I think I'm the only person between all of you all and dinner. I'll ask 2 more burning questions.
Good. No, you can. I can carry on. I'm sure Mimi and Vivian and Aarti are happy, and Komal are there.
Ma'am, Tejal is going to again ring the bell.
She got her alarm clocks again.
Teja, was that bell you again?
No, I did not ring the bell.
I had one burning question for Dr. Maithili, actually. If madam is still around, or in case, I think she's taken a break.
Dr. Mithili or Dr. Priya is also there, I think. Yeah, she's here. Ma'am is here.
Yeah, ma'am, I wanted to understand from you. I mean, there was this question which Dr. Rupa is asking us, that they see a lot of prescriptions of SERMs from the gynecologists. So what would be your take on SERMs versus HRT? I mean, which agents would you prefer in practice? That's what she wants to know.
Ma'am, you're mute.
Ma'am, you're muted.
I think most of the endos would agree with me that we use less of SERMs. Am I right, Sheila?
Very true, ma'am. Very true.
Very
Totally agree.
Initially, they were very much in vogue, but right now, yeah, Dr. Michaeli.
Yeah. So I don't know, I'm a late entry in endocrinology, so I always used hormone therapy, but I often see a good number of prescriptions of SERMs from the gynecologists.
Yes, very true.
Well, I'm not sure how, they score over hormone therapy, but by and large, the only SERM that is now come in the market is the bezodoxifene. The bezodoxifene is combined with estradiol, and then it obviates the need for using a progestin. Personally, I don't have any experience with this molecule, but maybe some of you from the bigger cities will be able to explain about the SERM which is available, bezodoxifene plus estradiol. Is it there in Mumbai?
We don't use it, Dr. Maithili. As you said, most endos, we never prescribe SERMs. I don't know about Dr. Vaishali in Pune.
Most of my gynec colleagues are using SERMs. The raloxifene is very commonly used by most of my gynec colleagues in the first year post-menopause. But as you rightly said, endocrines are not the ones who are using it very commonly.
I don't think I've used it at least in a decade now. Maybe initially when they were launched, yes, but no, not anymore.
So the take-home message would be that they do not have any advantage over the hormone therapy.
Yeah.
And as we already said, hormone therapy in menopause, you need to start with a low dose because you are concerned about alleviating vasomotor symptoms and the genitourinary syndrome. So you even the bone loss, you need a very small dose of estrogen. I think that's the take-home message.
My personal favorite, actually, I think it is discussion T-gel, and I realized that India doesn't have gel estrogels.
Yeah.
The estrogen gels.
Yeah,
I think that is fantastic product to use because it's just very much gentle and it removes the first pass effect from the liver. So that together with a progesterone, like Eutrogestin.
We do
So
use
that's good.
Primarin gel, ma'am. We do have Primarin gel with us, and we do use it in India also.
So for the last question,
yeah.
I think, last question to Cheryl. Cheryl, keto diet, what's your final word on it?
Rapid fire.
I'm not in for a keto diet at all. I think moderate carbs is the way to go. Moderate carbs, good protein, healthy fats. That is more sustainable and no complications.
Okay.
I think when it comes to weight, I think the most important decision-making question regarding how much a person can or max should weigh is when I asked them what was your weight at the age of 20 or 25. Because even a 140 kilo person might never have been less than 80 ever, so then I, even if that is overweight or obese for them, that is the target weight, isn't it? Yes. And what was discussed that we should know the weight gain desirable during pregnancy. I think these two things are very, very important to remember.
In fact, I think Shilpal also agree with me that in our clinic, at least when these female patients come, they'll always get their marriage photograph. And they'll, show it to us and they'll say, this is me. And then what happened? Marriage and babies. And so that's a very common thing that we encounter.
Okay. Like in, I think for the foreign faculty, I'm saying it like rose flower and cauliflower. So it's a difference between the look of a rose and a cauli. When we say gulab ka phool, or you understand?
We're supposed to be encouraging to women. We're not going to put them down and call them cauliflower.
In fact, I was just telling Dr. Shella, I worked with her, it's now 20 years that I worked with her 20 years ago and she still looks the same. So I think she hasn't changed at all.
HRT has made the difference.
That is it.
I think that was fantastic. It was great interacting with such great stalwarts, right from Bajaj ma'am to some of the fantastic faces from Mithili madam, who is so, such a fantastic person to work with. Vivian, Mimi, Professor Iraqi, thank you very much. I mean, everybody up there, rest everybody are my friends, so I won't, categorically talk to everybody, take everybody's names. But to close this meeting, I will have to invite Tejal up there, and Tejal is going to finally give, I think, the formal vote of thanks to everybody. But it was a pleasure. Thank you very much for being part of this fantastic meeting. Thank you. And thanks, Tejal and ma'am and Gagan, who is not here, but I'm sure she's around, for making me a part of this. It's been a real
thank you. A very, very special thanks to our international chairs, Vivian and Mimi. They've been just wonderful, wonderful. And we can't wait to have you back with us. And Vaishali is absolutely amazing. The way she handled the panel, Shifali, Shilpa, Cheryl, and unfortunately I missed out on the second panel because I was just trying to log in. But I attended Dr. Maithili and Priya as well. Absolutely wonderful. Thank you, Tejal. But see, like we always say, we need to give more time to our patients. So we need to have more time for more and more panels as well.
I hope next time we plan this. So I just wanted to speak in very brief. So what happened is at one of the meetings we had among endocrinologists, I was cribbing to Dr. Sanjay Kalra that, there are all men only meetings and there are a lot of panels and women are not involved a lot. So what happened is when Torrent was, talking to Dr. Kalra and they said that, Dr. Tejal Latia has been cribbing and complaining for a long time. So finally to shut me up, they said, let's do something which is exclusively for women. And I wanted, as I said at the beginning on day one, which Shefali remembers, so there are men only panels discussing everything from menstruation to menopause, right? But women who are experiencing it, their voice is often not heard. And that was the reason that Torrent gave us this opportunity, this platform, that we could talk about women. A special thanks to Dr. Sanjay Kalra because he heard me and he made sure that I got the medium that we could take this forward. And then Dr. Sarita and Dr. Gagan Priya joined me and we were able to do this wonderful program. We're hoping that we're able to carry this forward in the future, and we hope to involve all of you again and again over the next few months, and hopefully we'll be able to do this program maybe once every month or once every 2 months. Thank you from the bottom of my heart, all the faculty, all the chairpersons, all the panelists. Thank you very much, and good night. Only Renu has a few words to say from Torrent, and we can close the session. Renu, you want to wind up?
Thank you, ma'am. Thank you so much. At last, first of all, good evening, doctors. Once again, introducing myself, Renu Gangwani from Torrent Pharma. Well, after finishing the back-to-back 2 webinars of wellness and health, women's voices with a great success, once again, it is my great honor and privilege to offer the vote of thanks on behalf of Torrent Pharma. Firstly, for this grand success, I would like to thank the entire team of this webinar, including the faculty from India, as well as from the other parts of the world, who delivered their best to make it successful. Our special thanks to today's chairpersons, Dr. Sarita Bajaj, Dr. Vivian Lim, Dr. Mimigri, Dr. Jaideep Malhotra, Dr. Hinde Iraqi, and Dr. Sheila Sheikh for their scintillating contribution. We also extend our sincere thanks to today's reporters, Dr. Vaishali Deshmukh, Dr. Shifali Bardwaj, Dr. Arundhati Dasgupta, and Dr. Nilakshi Dekar for igniting the stimulating and interesting discussion. Further, on behalf of Torrent Pharma, we would like to express our sincere gratitude to our panelists, Dr. Komal Verma, Dr. Aarti Bell, Ms. Shilpa Joshi, Ms. Cheryl, Dr. A. Mithili, Dr. Priya, Dr. Chitra, and Dr. Tejal Ladhya, who enlightened us with the different aspects of women healthcare. At last, we would like to thank all our participants from across the globe for sparing their valuable time on this Sunday evening to be with us on this virtual platform. On behalf of Torrent Pharma, my heartfelt thanks to you all for being with us today. Hope to see you again. Till then, stay safe, stay protected,